Hello, Dr. Dave Webster, and this is my final video in a series about asking you whether to consider whether Cancer Care Ontario and our oncologists are friends or foes of the patients. We're now down to the most important question, and that is, are our oncologists, the doctors that treat cancer patients, are they friends of the patient, as you would hope, or are they friends of Cancer Care Ontario? This video is entitled My Disturbing Epiphany About a Patient's Oncologist. Now, if you've been following my videos and blog posts and so on, and this series, it simply is an undeniable fact. Cancer Care Ontario is not a friend of our patients. They have spent almost 20 years as enablers of Ontario government's healthcare agenda, which victimizes not just cancer patients, but all patients. Now, my epiphany case is this. I also, besides nuclear medicine, I see patients with osteoporosis and thyroid disease, so I was referred a patient from a family doctor. She's 52, has osteoporosis, but her history shows she's a smoker. She's got unexplained weight loss and something very concerning, no appetite. And this basically means to me that she has cancer. To prove it otherwise, I do a blood test and it shows her bones a little more active than it should be, and so I order a bone scan, and this is the bone scan here. Now, this looks at bone metabolism, PET scan looks at sugar metabolism. We have a finding here, for example, and that turns out that's just a trauma to her rib, so that's not of concern. But what it does show is something very concerning here. This is in the lumbar spine, and you can see that's the bone scan activity, and this is just the CT, and you can see that there's a sclerotic change, and this is going to be a spread of cancer to the bone. The problem is at this point, we don't know where that cancer is. But because it's a CT, I can look at the lungs, and she does have a new right lung nodule, so now I'm very concerned that she has stage 4 lung cancer. Now, I did my best to reassure the patient, but we want to obviously get tissue to see what's going on here. In the rest of the civilized medical world, beyond Ontario's borders where PET is available, that would be a PET scan. And her case will now demonstrate why it has been the standard for 20 years in places like Chile and Argentina. So again, this is sugar metabolism, and there's a number of findings about normal tissue in the heart and so on here, but there's some findings here. But let's just look at the nodule itself right here, and if we look at the fused image, you can see the nodule in the CT. But if you look at the amount of uptake, the blackness as it were there, it's pretty similar in that nodule to the rest of the tissue. So how do we become, how do we know whether we should be concerned or not? Well, we actually do compare the amount of uptake of the sugar in the nodule compared to normal tissue, and we get something called the standardized uptake value. We call it the SUV max, and we know that if the uptake in the nodule is 2.5 times or greater compared to normal tissue, that it has a 90% greater chance or so of being cancer. Doesn't mean it's cancer, so we now need tissue for sure to make the difference. But it's only 1.7. Now, if that's all we had seen, we would have said, maybe this isn't cancer, and we can maybe wait for a bit. But there were other findings on that scan, as you can see here, and these are what we are called mediastinal lymph nodes, or lymph nodes in the middle of the chest. And here's a little cartoon of that. Your trachea here, your clavicles, you can see here with the left lung bronchus in here, and we stage these little node stations. This is node station 7 and 1 and 2 up here, but these are for our lymph nodes, as you can see here. But the SUV max is 4, and that's very concerning. So now this demonstrates the PET, for example, information you could not possibly get from a CT or MR, something that makes treating cancer very difficult, and that demonstrates that the behavior of the metastasis can sometimes be quite different from the parent compound here. This appears to be much more aggressive, you see, and that creates some problems, as you can see, but only demonstrable on PET. But it also confirms that the bone scan was correct as well, that she does have this cancer here. That makes it a stage 4 lung cancer because it's outside the chest and it won't be curable, but it also had a very, very critical finding, and that is there's a little lymph node just behind the clavicle right there. You can hardly see it, but if we remind ourselves there, it's a 2R lymph node. Now, that's right there at the base of the neck, so that's pretty easy to get at. Whereas if we went after the nodule and the smoker, that could be very risky, and she could have had a collapsed lung and ended up in the ICU and so on. So I go to she's referred to the thoracic surgeon. He agrees. He does what's called a mediastinoscopy. We stick a little metal tube in there under a light anesthetic. We make an incision. Now it's virtually right there, and that because it was right behind the clavicle there. So I assist with these things routinely, and the time from the initial skin incision to sewing that and cutting the last suture would be about 10 to 12 minutes. And absolutely minimal risk to that patient. The biopsy confirms it's lung cancer. Now, to this point, we only have the bone scan and the PET CT, but we minimized the time between the first suspicion of cancer and the worry of that patient to tissue confirmation and stage 4. It's about 7 weeks, and we've minimized radiation risk for the patient because she did not have a diagnostic CT, which is normally compulsory, no risk of contrast, minimal risk from biopsies we've seen, and of course a reduced taxpayer cost. And how does that happen? Because if you have a lung nodule, you will know that it can easily be a year or more before they finally make the diagnosis when it turns out to be cancer, because they keep doing serial CTs with all that radiation exposure to you. And then once they think, gee, maybe there's some concern here, you don't get a PET. You have to have the biopsy. And the anxiety for these patients is horrible. I had a patient say to me, doctor, my life is on hold. I can't sleep. I can't focus on anything else. But I can assure you this is of absolutely zero concern to Cancer Care Ontario or the oncologists. Now, of course, the anxiety for this patient, this news is terrible news, but the point is we minimize the length of time between her fretting about it and actually now moving on as cancer patients to the next phase of dealing with that, right? But because it's not a curable cancer being stage 4, we'll talk about what that means, because there'll be other uses for PET there. But she is referred to an oncologist, but it's been 3 or 4 weeks. He's not seen her. I email him. He says, well, I'm refused to see this lady until she has a diagnostic CT of her chest, abdomen, pelvis. Now, that's about 300 chest x-rays worth of radiation exposure. That's no problem, is if there's a reason to do it, but I would suggest that there isn't, and certainly the rest of the world would say the same thing based on science. But then he blames me for the delay because I should have ordered the tests. But I point out to him, I say, listen, that diagnostic CT is not going to add anything that we don't already know from the PET scan, so you can make decisions now. It'll have characterized any tissue, whether we should be concerned about it or not, but very critically, that 2R node that allowed us to make that so safe and quick for her and get the diagnosis, that would have been normal size in CT, and they never would have seen it. Now, here's the second use of PET in this particular case. There are many uses, but in now this patient is good, again, going on palliative therapy. It's not to cure, but it's to, hopefully we can give her as much life length of time, but with quality as possible. And therefore, we can use PET scanning to determine the response to therapy. And in palliative therapy, and even in active therapy, we can look after 1 or even 2 cycles. Normally, you would get 6 cycles, but this is one of the reasons that PET was designated the cornerstone of imaging management in the era of personalized medicine, and that's more than a decade ago. But it's personalized because the individual patient, you can see the response and then make decisions. So here's a patient with a cancer of the left tonsil. The original SUV max before treatment is 6. After, it's 1. Now, if that was this patient, then you would say, great, I can show the patient it's working. Yes, there's lots of risks and side effects, but it's worth it because it's working. But what about this patient here? Here's a little cancer sitting under the patient. This is the jaw here, the right jaw. And interestingly, the initial SUV max is only 3.5. But after those 2 cycles, it's now 5.2. Clearly, the therapy is not only working, but she's actually worse, right? This is horrible news for the patient, but it is the truth. And if there are no other options, then the patient can look at this and get their personalized response and say, look, I'm going to stop this and I'm going to spend quality of life with my patient. So again, I asked the oncologist to defend what he wants. That's those diagnostic TTs. I asked whether or not he's going to allow us to order the PET after 2 cycles, and his response is this. He actually tells the patient and I that he really doesn't think that PET's been very useful. Just think about that for a minute. But then he reports me to the chief of staff of the hospital, and what he says is I'm acting beyond my scope of practice. Now think about that for a moment. I am an imaging specialist. That's what I do for a living. I've asked him some imaging questions, but somehow I've asked him a question I guess he didn't want to, and he didn't very comfortable with or wanted to answer. But in addition, I'm delaying it, of course, but most importantly, one of her stresses is going to be that I am giving her conflicting information compared to what he's telling her. But remember, I'm giving her information based on the most current medical scientific literature. Her oncologist is giving her information based on a political agenda from Cancer Care Ontario and not based on science. So what happened next was made it absolutely crystal clear to me, and you can decide for yourself, is Cancer Care Ontario pulling the strings of the puppet master of our oncologist? What happened next was a couple of days later, there's a letter not now from the oncologist to the chief of staff, but now from the chief of the department demanding I be reviewed immediately by the medical advisory committee. And the information that led to that letter, only Cancer Care Ontario executives would have known about, that so outraged to our oncologist. So you can decide for yourself who manipulated our oncologist to now ramp up their threats to me. But let's get back to that patient, because they're always caught in the middle, and the victims, as I've said. So she will not get they will not order another PET scan after 2 cycles of therapy, so she can make that critical decision. You can ask yourself, can you think of a reason why? I certainly can't. But if she survives the now 6 cycles she will only be allowed to see a CT exam to determine whether it's responding. The oncologists are fully aware that the CT has zero ability to determine whether or not that the mass, any masses that are left that are scar tissue and therefore the therapy worked, or it actually indicates active cancer. Big difference for the patient, but they don't care. So obviously I don't need to emphasize this to you, but it cannot be overemphasized emphasize the implications for this patient, as you can imagine, are critical for cancer patients in general. But there's lots of other reasons, lots of other health issues where PET has been the cornerstone of imaging management for a very long time. We have this aging population. Everybody's concerned, do I have dementia? That is the world standard, except in Ontario. But this isn't just about PET. All that infrastructure, experts and cost and so on, it isn't just about to block PET. PET is just simply the best example of how critical healthcare policies have been made and continue to be made in Ontario. I know what about your doctors, so clearly we are forced to practice substandard, even incompetent or harmful medicine on our patients, and don't you dare, as you can see now, ask Ontario's oncologists to ask questions or give them any advice from an imaging expert as to how they might approach this patient, because if they don't like that question, just like their paymasters, Cancer Care Ontario, your doctor may find yourself being threatened, just as I have been. So here we are back to the original question. I think you have enough information to make up your own minds. Where do the loyalties of Ontario's oncologists lie? With you, their patients, or with their paymasters, Cancer Care Ontario? Now, my conclusions are this, that our oncologists, they are not acting in the best interest of these patients. They are acting as agents of Cancer Care Ontario's mandate to come up with answers that Ontario politicians need to justify whatever healthcare policies they've decided on based on a political agenda and not science. In short, our Ontario oncologists are knowingly and therefore deliberately practicing substandard or worse medicine. Now, if you're disturbed by your conclusions and now may have serious concerns about medical care in Ontario, you're not alone, and you need to be very, very concerned. The only way that Ontario patients will finally be allowed access to having 2018 levels of medical care from advanced medical jurisdictions and access to physicians who are not agents of the government, then what we need to do is demand that the Ford government, Cancer Care Ontario, and their colleagues at McMaster University finally defend how healthcare policies are made and finally start answering the questions raised since 2005 by Canadian and international medical experts about these severe and unprecedented accusations of unethical and immoral trials. We need to get on social media a groundswell of public outcry to demand that the 2005, think of that, 2005 motions from the Canadian Association of Nuclear Medicine, which declared the trials unethical. Those trials continue to this day, but they also recommended an immediate investigation by the Canadian experts in ethics and healthcare policy. We need to make sure that happens to finally move forward, but also make sure that the politicians cannot continue to get away with this on our patients. So here's my website and information. Please do what you can to get the information out. And if you're not already suffering from or concerned about serious healthcare issues, someday you or loved ones might be, and you'll find yourself in the crosshairs of Ontario's politicians. And I would suggest to you that may be very detrimental to your health. Thanks for listening.